It is my pleasure to welcome in Greece, in Thessaloniki, our friend Venerino Poletti. Venerino Poletti is my mentor in European Respiratory Society, and if I asked all of you to be my ambassadors in this difficult trip through the election, Venerino is my senior and main ambassador all over the world, and he teaches me a lot of things. We know each other from Venice in 2001 in a lovely Vasong Congress. He was next to me. He teach me how to do with the European Respiratory Society. We have worked very closely together. I hope that I did my best to work as a team with Venerino because he is very creative. He knows a lot of things. He is a pioneer in different aspects of interstitial lung disease, from pathology to interventional medicine. He's a friend. I feel family with Venerino, and I think that he feels the same. So this is nice, very nice. He will talk to us about survival IPF. So the floor is yours, and we are looking forward to your talk.
Kalimera, it's the only few words I know in Greek, sorry. Thank you, Katerina, for your kind introduction. Thanks to the Hellenic Chest Disease Society for the kind invitation. And these are my conflict of interest. I start with this. You know that in April, that was the 300th anniversary of birth of Immanuel Kant. And in his famous critiques, he started with 3 questions. What can I know? What should I do? What may I legitimately hope? And I will try to follow this track in my presentation. You know, when we have firm data on IPF, a decline, a 5% of decline in FVC over 1 year is associated with an approximately 2-fold increase in mortality compared with no change. Antifibrotic therapy reduce the declining of FVC in individuals with IPF. After lung transplant, patients prolong their life expectancy, and up to 85% of individuals with end-stage fibrotic ILD develop pulmonary hypertension. But, of course, IPF remains a relentlessly progressive disease with dismal prognosis, but rate of decline and treatment response in individual patients is highly unpredictable. We have already seen that artificial intelligence, that I think could be an important change in our next future, can help us to identify patients that can progress more rapidly. This is a paper just online by the Brompton Hospital showing that fibrotic extension and vascular, for example, component are associated to, are predictor of progression. But we have other point to consider. What is the role of morphological pattern UIP in the progression of the disease? We know that cryobiopsy can identify UIP thanks to the paper by a lot of papers. The last one was from Lauren Troy and the other Australian group, and we showed that independently from the final clinical diagnosis, UIP in cryobiopsy is associated with a bad prognosis. So UIP could be the core business of the problem. This was recently underlined by this study 210 patients with a diagnosis of progressive pulmonary fibrosis, not IAP, and they assessed the presence and extent of UIP in surgical lung biopsy. The study was done in Japan, and you see that UIP pattern, morphologically speaking, involve more than 10% of the biopsies area. The prognosis is significantly worse. We have also documentation, thanks to a lot of studies using more sophisticated tools, that different entities or entities that are called in a different manner can have at least a subset of these disorders, can have a molecular background that is typically observed in IPF patients, and when this molecular background is present, the prognosis is similar to IPF or identical to IPF. We know that senescence of type 2 pneumocytes is a common element shared by different entities included in the group called progressive pulmonary fibrosis and in IPF. So this is the hypothesis suggested by Selman, DiPardo, and Atul Wells that UIP could be the core business, not the clinical diagnosis, but the background that could be idiopathic, could be related collagen vascular diseases, could be observed in patients with a diagnosis of hypersensitivity pneumonitis. And I think that this could be true, so we can know it. We are still in the question one. We can know it if we go into deeply and with attention in this study. We know that in UIP we have the so-called alveolar stem cell exhaustion. So type 2 pneumocytes that are the alveolar stem cells are senescent, tend to disappear, but they acquire a specific phenotype. This biological phenotype has been first described in Hodgkin disease, and it is called senescent associated secretory phenotype. They are senescent, but they are still able to trigger or to incite aberrant activation, not activation of aberrant pathways, but aberrant activation of normal pathways. The first pathway identified was Wnt pathway, and then we have a lot of other elements documenting that there is an activation of pathways related to embryogenesis and to carcinogenesis. So what happens in the alveolar spaces when we have these two steps? We have a profibrotic microenvironment, and interestingly, we have fibroblastic foci that we can call alveolar fibroblastic foci because they are covered this ellipsoidal structure containing extracellular matrix rich in tenosyne and myofibroblast are covered by type 2 pneumocytes. But the third stage, and we are still in the question one, is the proliferation of basaloid bronchiolar-like cells. This was reported by our group in 2006 and in other papers. So we have these cells that have a bronchial phenotype, not a typical bronchial phenotype, that express markers that are shared by neoplastic cells, markers for migration and for invasiveness. And this was confirmed quite recently by the Kaminsky group, showing that in UIP there are aberrant basaloid cells that co-express basal, epithelial, mesenchymal, senescent, and developmental markers. So the first question, what can I know? UIP pattern, a biological process shared between IPF and a variety of so-called progressive pulmonary fibrosis entities, and this biological pattern is characterized by 3 steps: alveolar stem cell exhaustion with senescence of type 2 pneumocytes, acquisition of senescent associated secretory phenotype, atypical bronchiolar or bronchial-like cells proliferation, the so-called onacambing, and for that we know why these patients are prone to develop very specific or typical cancers. And UIP, and these are studies that we are ending, or we are finalizing with the Kaminsky group on cryobiopsy. UIP is UIP from the beginning. You can have a lung with different entities, but when UIP appears, it is UIP from the beginning. So what I should do? Identify the UIP pattern. This is the first step. See if I have bronchiolar fibroblastic foci, as in the upper right corner, if I have onacambing, if I have patchy fibrosis. And this can be done in a very early stage if you use a semi-invasive approach and specific guiding system. This is our study on cone-beam CT as a tool in the biopsy of patients with very early disease, not typical UIP, of course, with an extension less than 15% of the area of the volume. And this was a prospective study, 36 patients, and you see here we had UIP in 25% of the cases from the beginning. Another point is that UIP could be the core business of entities that are not IPF. This is another study. We collected 2 cohorts of patients with a diagnosis of fibrosing HP according to the recent guidelines. All the material was reviewed by radiologists and pathologists. The 2 cohorts come from Forlì Hospital and Aarhus Hospital. And you see if we have UIP pattern as the background, the fibrotic HP becomes, clinically speaking, an IPF. And I don't present here the data. We have similar data for collagen neurovascular disease. We have a multi-center study with Vancouver, with Prague, with Mayo Clinic in Scottsdale, and 25% of the cases without UIP pattern in CT scan had UIP in histology. We can recognize UIP also using more sophisticated approaches, genetic and genomic studies, as shown by the Schwartz study. We can have more sophisticated analysis, single cell profiling, revealing the role even of immunity, because senescence is associated with an increase of autoimmunity. We know that a lot of disorders that are senescent associated, the typical model is myelodysplasia. You have an increase of autoimmunity or autoinflammatory background, and we can recognize specific pathway that can be druggable. So what could happen? We know that we can answer to the second question, identification of a UIP pattern as early as possible, identification of the more relevant pathogenetic events in the patient, in the specific patient, validation of minimally invasive approaches to obtain biological material, possibly identification of biomarkers, and identification of efficacious treatment. And this is what we can legitimately hope, not what can we hope without a rational background. We know that we have drugs that can reduce the declining of the progression of the disease. We know that it can happen as expected if you have in mind the biological background in other progressive pulmonary fibrosis entities. With both drugs, nintedanib and pirfenidone, can happen in scleroderma. So can happen in rheumatoid arthritis. So we are moving our attention and our clinical practice from entities identified by clinical radiological test to entities that are defined by biological background. That this is what happened already in the oncological field. We know that lymphoma, the oldest one here, I think I am one of the oldest one, the classification of lymphoma was nodular diffuse, Rappaport classification. Lucas and Collin classification, do you remember? Centrocytic, centroblastic, and small lymphocytic lymphoma. Now, if you want to have a diagnosis of a lymphoma, you have a list of monoclonal antibodies that is more than one sheet of paper. This happens in lung cancer. Now the diagnosis of adenocarcinoma is no longer a diagnosis, no longer an acceptable diagnosis. So our hope, legitimately hope, is that we can recognize drugs that are based or identified or used according to specific or well-known pathogenetic background. And we know that we have a lot of trials, not only for IPF. This is the list of trials in my department. So I think that what we can legitimately know in the future is that we can treat better and with more valid result for the patient these disorders. But I would like to conclude with a quotation that is important. I am here in the country, in the land that I consider the cradle of our culture. And we started with this. We know what it's very well established is that we know that we don't know. And this is very important to maintain our research activity, to maintain our enthusiasm to this approach. Thank you very much for your attention.
I would like to thank you very much for your talk. Since you said secretory-associated phenotype with aging, the next step is defective autophagy. And the secret in IPF lies in defective autophagy. Autophagy means energy, means mitochondria. And there is also a new cell that has been discovered recently besides basaloid. These are called ionocytes that are also participating in the fibrosis process. And the third thing I want to tell you is, if you excuse me, we should not forget that the TOLIP mutation is 20%. And the TOLIP mutation is different, and there is a response to therapy with acetylcysteine. And in the old time, we said, TOLIP, no, don't forget it, it's 20%.
Yes, thank you. We are waiting for the result. I don't know if they're still ongoing. Yeah.
Thank you for your talk, as always, very interesting with this philosophical touch.
You know what is my master.
So I was impressed when I heard about the cone beam CT last year in Ancona when Claudia Ravaglia presented the results. Do you think that, as you said, Lance, that once it is a UIP, it is always a UIP. So if with the cone beam CT we recognize very early UIP patterns, do you think that if we enrich our clinical cohorts with these patients, would we see a better signal from the
we see, sorry?
If we can see a better signal from the antifibrotic drugs, if we can if we can enrich our clinical trial cohorts with this type of patients who have a very early stage IPF?
This is a very difficult question because to have the results with the recruitment of these patients, you need a long time because the IPF, the subclinical length of IPF is around 10 years. So it's
the
difficult.
52 weeks of the clinical trial is too short.
Yeah. So, but it's interesting to, now we know that ILA is a big business. And ILA for me was invented, I do not know if we have radiologists in the room, was invented by radiologists to find a new job. But ILA, it's like to have a nodule. So the job starts for us, yes.
Thank you.
Athena would like to conclude as our discussant.
Thank you. Thank you for this excellent presentation.
Can you
Professor
speak?
Poletti.
I'm a little bit old.
Okay. I have the impression that we have learned a lot about IPF, but we don't know many things. So some patients go slowly, and others, they go very fast. Although they have the same picture profile, we don't perform biopsies to see fibroblastic foci, so we cannot predict by histology. I think there are other patterns that we haven't discovered. It's very complicated, and the lack of biomarkers is a problem for these patients. So we can predict in a way how they will progress. You can make a comment on that.
Biomarkers is still a big problem because I am hearing of biomarkers since 15 years, I think, so nothing changed definitely. Regarding the subset of IPF of UIP is interesting because I didn't have time enough to go into details. But in cryobiopsy, you have, for example, cases with a huge component of fibroelastotic tissue, other cases with evident bronchiolar fibroblastic foci instead of alveolar fibroblastic foci. I think that these two types of fibroblastic foci are completely different. And we have cases in which you have bone metaplasia. You can see it also in CT scan, but not completely. So I guess that if you want to be more precise, tissue is still the issue, yeah.
Thank you so much. Unfortunately, for housekeeping reasons, we have to go to the next satellite symposium. Thank you so much. We have the opportunity to have Venerino's excellent courses in Ravenna early October. And we will have more ILD in share Congress in Crete with Venerino. So we will have different opportunities. Thank you so much. And please do not forget to vote. Thank you so much.